live webinar. And for those of you who join in for the first time, it's 30 minutes with a short discussion of 2 papers, each 10 minutes this presentation, followed by a 5-minute discussion. Today we have 2 papers that both relate to dark spots and but in very different ways. So the first one, and we'll dive right into it. And I want to thank Alessandra Scataya as the first author to present that. She is from the Division of Cardiology, Villa dei Fiori Hospital in Acerra in Italy. And then we have as the second paper, we have Nilesh Gugre from Toronto with paper. First author is Stephania Assimopoulos on hemorrhage. So both papers I find very interesting. So let's just start. And if you could, Alessandra, if you could share your screen and walk us through the PDF. And the paper is entitled Abnormal Papillary Muscle Signal on Cine MRI as a Typical Feature of Mitral Valve Prolapse. So mitral valve prolapse is a phenomenon that has been a little bit overcalled when I was a young resident, but now we understand that this is maybe not that frequent, the disease, but it has severe implications for the people who have it, because typically in their 5th, 6th decade, they get into a mitral valve regurgitation, arrhythmia, and often end up with mitral valve replacement. And because it's sometimes difficult to diagnose it, it's important to look at new ways to better identify it earlier. And therefore, this paper, I think, is clinically very important. Alessandra, take it from here.
Okay, so thank you very much. Thank you, Matthias, and good morning and good afternoon to everybody. So as you were saying, yes, the diagnosis of papillary of mitral valve prolapse can be very tricky and very difficult. So basically what we did was trying to prove an impression that we had. So if you go straight to the last picture, I know that it's a little bit of a jump, but I'll go back later. So this is the picture. This is just a drawing, and this represents our impression. So basically, what we notice is that in patients with mitral valve prolapse, there was a different signal of the papillary muscles. So more specifically, the papillary muscles appear to be darker compared to the signal of the LV myocardium. And that was evident on classical Cine MRI imaging. So what we wanted to do was to prove this impression and to see if this impression can mean anything. So basically what we did, we enrolled a different group of patients. So we enrolled 47 patients with mitral valve prolapse. At the moment of enrollment, we also recorded any previous evidence of complex ventricular arrhythmias. We just focused on the malignant arrhythmias. We did not consider an arrhythmic phenotype when it was just simple ectopics. Then we also decided to enroll in this study different groups, more specifically, a patient with mitral regurgitation, at least moderate, from mechanism other than mitral valve prolapse, then patient with hypertrophic cardiomyopathy, and of course, healthy volunteers. So we did choose mitral regurgitation and HCM patient because these are diseases that typically involves the subvalvular apparatus of the mitral valve as well. So what we wanted to see was if this sign was clear, if we can prove that this sign is evident, and if it was a specific sign of mitral valve prolapse, or was something that you could see in every disease that involves the mitral valve apparatus. So all the scanners were performed with a 1.5 Tesla. It was just a typical CMR scanner, so with classical Cine steady state Cine images. And LGE images, we focused on a qualitative assessment of LGE. Recently, it has been described that LGE in mitral valve prolapse can be quite frequent, localized in the papillary muscles or in the LV as well. And so we decided to report if it was present or not with no quantification of it. After that, we basically perform the image analysis in this way. So we pick a mid-ventricular short axis Cine image in end systolic phase, because to our experience is like the best way to see the papillary muscles. And then we first did like a kind of a visual score. So we just said, okay, the papillary muscles are darker, and we gave, like a 0.1. Or we said, no, they are like normal myocardium. So this is a picture that is showing what I wanted to say to you. So the first letter A, B, and C show mitral valve prolapse patient. And then you have an healthy volunteer, a patient with HCM, obviously, and a patient with a severe mitral regurgitation. So it's the same, of course, it's the same phase. And you can see visually that the papillary muscle signal appear to be different compared to the LV in only the MVP patient, not also in the other conditions that I talked to you about. After this first visual estimation, we decided to prove it. So we tried to measure the signal intensity of the papillary muscles and of the myocardium. And we did it by drawing a region of interest in the same slides that I was talking to you about before. After that, basically, we just indexed the signal intensity of the papillary muscles for the one of the LV myocardium. And we obtained two ratios that we called APS ratio and PPS ratio. Of course, one for the anterolateral papillary muscles and the other one for the posteromedial papillary muscle. So we then compared these ratios, the values of this ratio in the study groups. And this is what came out, basically. So as you can see in this table, only in MVP patient, the values of this ratio was a little bit lower compared to all the others. So usually it's a ratio around 1 in healthy volunteers, 1.1 in mitral regurgitation, and so on. While in mitral valve prolapse, this ratio is quite low. And this is also represented with this box plot down here. So the ratio, both the ratio in the mitral valve prolapse is quite low compared to the other condition. After that, we decided to test the diagnostic accuracy of this ratio. So we performed receiving operator curve analysis, and we found that a values of like 0.8 for both the ratio was at a value with a very good sensibility and specificity, as well as positive and negative predictive values in identifying patient with mitral valve prolapse. After all of this, we also try to see if there was an agreement with what we were, see to the naked eye and what we can actually measure with all these signal intensity evaluation. And there was indeed a very good agreement with the K of Cohen. So after all of this, we said, okay, we have this sign it appeared to be very specific for mitral valve prolapse and not fine. We cannot see it in any other condition, or at least in those conditions that I told you about. But we said, okay, let's see if this sign means anything. So we divided the mitral valve prolapse population in patients that had significant mitral regurgitation or not, then in patients that had LGE or not, and in patients that were having a clinical expression of arrhythmias, especially malignant arrhythmias, as I told you before. However, this sign, not the sign, but still the values of the ratios were not really different in these subgroups. There was no statistically significant difference. What we can say is that, however, the incidence of LGE in our population of mitral valve prolapse was very low. And the same we can say for the incidence, for example, of arrhythmias, of malignant arrhythmias. So we have just a 15% of cases with LGE, with just one patient had LGE in the LV instead of the papillary muscles. And also the patient with malignant arrhythmias were just 8 out of 47, so just 17%. Of course, we also test inter-observer and intra-observer reproducibility, and it was all very good. So basically, the finding of this paper are three. So the first one is that in the mitral valve prolapse only, the papillary muscles show a different signal on the classical Cine MRI images, and more precisely, they are darker. Apart from that, this imaging feature appears to be very specific of mitral valve prolapse, but however, in our population, it is not really linked to the demonstration of myocardial fibrosis or to the occurrence of significant arrhythmias. So reason for that, so we thought that this aspect of the papillary muscles can be related to the traction or the complex dynamics of the mitral valve apparatus in this condition, which is very, very complicated. And maybe we think, can it be like an early sign? So can we have it before having a real expression of LGE, the presence of, fibrosis in the papillary muscles? We don't know, of course. And regarding the low incidence of LGE and arrhythmias in our population, we can say that probably it was just a benign population, a population with a very benign mitral valve prolapse compared to those mainly reported in literature in which there were many cases of sudden cardiac death or complex ventricular arrhythmias, for example. As main limitation, I can say that, first of all, this is just a single center study. So it will be nice to hear if you have the same impression while you are reporting CMR scans and you look at the possible mitral valve prolapse. And it will be very nice to do to increase the number of center and to do a very big study, probably to assess the exact incidence of this sign and also to see if can be related to something clinically relevant in the progression of mitral valve prolapse. So thank you very much.
Thank you. Mille grazie. So that was great. And it's actually really very interesting. I have, of course, a few questions. We don't have a lot of time, but first of all, I was surprised about the specificity you found, because I had the feeling sometimes in patients with coronary artery disease that there was also low signal intensity, but I saw that in your control group, there were not necessarily patients with coronary artery disease. So I wonder, that's why I'm wondering, did you have any experience with those patients, or you focus on the comparison with mitral valve regurgitation and hypertrophic cardiomyopathy?
So we did exclude coronary artery disease. Basically, I can say that from time to time you can have, of course, mitral valve infarction, for example, in these cases. So you can clearly see it. So we didn't want either the signal of the papillary muscles or the one of the myocardium to be altered by the presence of fibrosis of like necrosis at all. It can happen to see it a little bit also in these cases, but to be honest, in my experience, I see it mainly in this type of patient. So okay. Just mitral valve.
Yeah. But that brings me to the other, and of course, the big elephant in the room is here. What is that? Why do we have a low signal intensity in the, so you already said, I mean, reasons for low signal intensity in these Cine images, they are T2 over T1 weighted, would be either a very low T2, like you have a hemorrhage in there, or an intrawall hemorrhage, or you have severe regional iron deposition, which we usually don't see, and fatty infiltration. But what were your thoughts? In the discussion, you allude to that a little bit, but what is your guess? What is that?
So my guess is that, but it's just my guess, of course. So it's that there's like chronic insult constant on the papillary muscles. But we also tried in a few very few patients to perform T1 mapping, for example, in end systolic phase, to better see the papillary muscles and to see if there was something different in the T1 values. But T1 mapping is hard to be constant and reproducible on the left ventricle. So with the papillary muscles, it's even worse. So I think that as the papillary muscles are made in this way, it's really difficult to do an appropriate tissue characterization of them. But mainly one day we will get to that. And I think that it's, like a chronic insult, like chronic damage to them. I just think that for now. What do you think?
And I would throw in a hypothesis, and the Cine images, they have a certain sensitivity for the so-called bold effect. So the oxygenation of the blood will reduce T2 and therefore would lead to a lowering of the signal. And as probably many of you know, I've been doing quite a lot of research over the last 15, 20 years on bold sensitive MR of the heart. And what we have seen is that in patients with severe coronary artery disease during adenosine, there is even a visible decrease of the signal intensity. So we're currently performing an international trial where we assess the impact of breathing maneuvers on the bold sensitive signal intensity. And we have some very encouraging results from some clinical trials from our center, but also from Boston and from Bern. So it could be actually that the constant stress of the two big valves on the papillary muscle causes a significant reduction of the oxygenation in the papillary muscle, leading to a bold effect, leading to a signal intensity decrease. But this, of course, would have to be somehow proven. So I just wanted to throw that in there, and then and then we have to stop and move on to the next paper. What I would suggest is, and you offered that, and I think it would be great if we could all meet in 2 months for the Journal Club of the February edition.
Okay.
And we ask people what their experience is, and we can ask around, and then you have a feedback from a number of people, and then maybe you can then also, if you share email address, which is of course now anyways known, then you find people then for a multi-center trial. So that would be wonderful.
Yeah, that would be amazing. Thank you very much.
So again, thank you very much for this very interesting overview of your paper. So now let's move on to a paper which will be even tougher to compress to 10 minutes. But Nilesh, I ask you to do your very best. It's extremely relevant, I think. Hemorrhage is a totally underrated complication of reperfused MI. Not enough people are thinking about that, and I think it creates really significant damage and may even be the cause for sudden death. So Nilesh and the group with Graham Wright, they're known for excellent and outstanding and cutting edge work. So I'm really looking forward to your paper that's entitled "Hemorrhage Promotes Chronic Adverse Remodeling in Acute Myocardial Infarction at T1, T2, and BOLD Study." Nilesh.
All right. Thank you very much for the invitation, firstly, and I think you set up the stage for hemorrhage. I think so. This is kind of just a quick background. I think this paper is essentially a sequel to our previous paper, which appeared in JCMR 2-3 years ago. And I'll talk a bit about the model that we developed for this. So as Matthias said, hemorrhage is a major confounder as part of the ischemia reperfusion injury post and acute myocardial infarction. And again, many clinical studies have now, I think, confirmed that this essentially has predictive power probably greater than microvascular obstruction and even infarct size. So this has adverse health outcomes long term. So you can see here that hemorrhage can also occur in as many as 50 to 75% of microvascular obstruction cases. And again, CMR is pretty robust in trying to in detecting these hemorrhage, this hemorrhage or the iron degradation products. T2 and T2 star sequences have been really instrumental in this case. So what going forward, so basically our previous study which tried to tackle the issue is that although all these clinical studies have shown this, the individual contribution of hemorrhage is still kind of in question, because it typically occurs in association with microvascular obstruction and these large infarcts. So our idea was whether we could tease out the individual contributions and additive contributions of hemorrhage. So I'll talk about the model that we used for this. So we used pigs as the pig model to understand this. And so what we did was we didn't want hemorrhage to be associated with only an ischemic injury. So we wanted to see if we introduced hemorrhage alone, what essentially would happen. So to do this, what we did was to introduce collagenase. Collagenase are enzymes which can break down the extracellular matrix. So we delivered this or administered this collagenase into the left anterior descending artery, typically where an occlusion is found. So we did 3 groups of animals. The first group essentially is an 8-minute ischemia, which shouldn't cause an infarction essentially, and then with collagenase. So that essentially should be a hemorrhage only group. The second group is a 45-minute ischemia. And we've shown previously that with 45 minutes in pigs, you don't really see hemorrhage, but you see small infarction, like heterogeneous small focal infarction. The third group, again, now, so that's the control group, only 45-minute ischemia. The third group is 45 minutes ischemia with collagenase. So you expect some, do we see some sort of interaction between ischemia and hemorrhage? And that was the third group. So I'll move ahead. Okay, CMR protocols. Again, this was on a 3 Tesla scanner. Typically, this was a very comprehensive scan with T2 imaging, T1 imaging with Molly. T2 imaging also we performed post injection of dipridamole as a stress agent, early guide, late guide enhancement, and then T1 mapping post contrast as well to look at partition coefficient. So that was kind of the protocol. I'm just going to go down. Okay, so this kind of image, this sort of image panel summarizes the LGE findings. The top row is, we call it a kind of plus hem, which is hemorrhage only. The central row is essentially the control group, which is 45-minute ischemia alone. And the bottom row is essentially ischemia with hemorrhage or collagenase. So you can see that in the last group where there's some sort of interaction happening, in some cases, nearly 40% of the cases, we also saw microvascular obstruction. And that was an interesting finding. We didn't really expect that. So which means that hemorrhage or the associated inflammation is actually having some sort of effect on the microvasculature as well. So that was kind of interesting. In general, we saw that the infarct size was also or LGE positive signal was also the highest in the last group. The hemorrhage only group did not really show anything LGE positive. So it was just saying that, okay, there's these red blood cells in the medium, but not really any sort of necrosis there, although there might be on histology. Looking at function, so this was interesting. So this is ejection fraction and diastolic volume. Both the hemorrhage groups did show a reduction in EF from day 1, and then at week 4, essentially they did start recovering. But in the control group, we didn't really see any sort of effect, as that was kind of expected. Interestingly, end diastolic volume also in both the hemorrhage groups was significantly elevated at week 4 compared to baseline, and that was not true in the control group. So it was interesting that hemorrhage alone could actually kind of have this sort of impact. Next, so This is just a figure, sort of a panel, sort of confirming that yes, using T2 star imaging, we can see these dark signal voids in the anterior region, uh, indicating ion byproducts or breakdown products. And this essentially just confirms that, okay, yes, indeed, that these two groups where we introduce collagenase do in fact show hemorrhage because of the reduced T2 star values in that region. Let me just go forward. I guess these are just pretty images kind of showing in the three groups, what does T1 mapping and T2 mapping show? I guess the point to note is that in the third group, where we did see uh, hemorrhage and in some case, in this case, microvascular obstruction, we saw this big region of T2 depression within the bright region of edema. So that's again typical of what you would see in these big infarcts. But remember that this was only a 45-minute occlusion with hemorrhage. So this is again just summarizing kind of the same thing, that with native T2 we are seeing elevation in T2 signal in the third group, which was a combinational group. T1 essentially showed the same thing, indicating edema or inflammation downstream post this event. Looking at post GAD T1, we're also seeing lower T1s in this injury region, and also a bigger partition coefficient, kind of indicating that there has been some sort of matrix alteration or expansion in the combinational group. Lastly, so this is, we also looked at the remote myocardium, which is kind of interesting because that's something that do you expect to see any sort of remote changes because there's remodeling happening. T2, again, it's interesting that we saw a slight T2 elevation in only the hemorrhagic groups between day 1 and week 1, which it's a very subtle change, and it could indicate a number of things. It could be potentially just mild edema in the remote myocardium as a result of this global inflammatory response. It could also mean hyperemia, as Matthias talked about, just the bold effect. Is there more oxygen demand in that region and that is why we are seeing this T2 elevation? It's not 100% clear. We also saw post contrast T1 a reduction in that value. Again, subtle, but does it potentially is there some sort of matrix expansion happening, which talks back to the presence of edema? That could be an interpretation, although that's not clear. Same with partition coefficient, kind of kind of reflected the same as what we saw with T1 post-GAD. The last one here, the fourth plot, is again interesting. So this was actually post, comparing T1 rest, T2 rest versus post dipridamol, which talks about the bold effect essentially. So what we saw is that in the hemorrhage groups, in both the hemorrhage groups, we saw a decrease in the sort of T2 change with a stress agent, which potentially ideally you should be able to see, just like the control group, you want an increase in T2 value, indicating there's more oxygenation happening in that tissue. But it seems that there is some vasodilator dysfunction happening in the remote myocardium, which is kind of interesting. And I guess the point to highlight is that the red is essentially here is hemorrhage only. There's no ischemia. There's really no infarction. So hemorrhage alone, or having red blood cells dispersed in some region of the heart, may have some sort of global effect. That's what this is telling us. Almost close to the end now. This is just histology in these three representative animals. And you can see that this is a Prussian blue stain at the bottom, fibrosis, trichrome stain, which is essentially collagen deposition in the center row. And you can see that in the combinational group where we had ischemia and hemorrhage, there is still some positive blue staining here, indicates that there is residual or ion deposition at the 4-week time point. Now, T2 star did not completely catch that. Probably it's difficult to catch finer traces which are apparent on histology. But it indicates that this sort of chronic deposition is possible, with these sort of severe insults. I think that's mostly it. But I think the one point I do want to make is the limitations. Is that we try to tease out this sort of effect, but again, it's important to remember that this is not the exact model. This model does not exactly represent what's happening in patients, because it's slightly different. Where typically in patients you would have these large transmural infarcts, microvascular obstruction, and then a subset is hemorrhage. But here it's slightly different, where you could have hemorrhage, which is right in any region of the the LAD territory. So the model is a bit different, and I think we just need to recognize that. So okay, this bottom line. So it does seem that hemorrhage alone is and has some alone is an active modulator of the inflammatory as well as the remodeling processes. Could have could also impact vasodilator dysfunction, and beyond all these effects of the initial ischemic insult. And I think it's important to focus on what do we do with this hemorrhage, and I think it's a big deal to figure out how to monitor and what to do with these patients. So yeah, I'll end with that.
Thank you very much. And it would, of course, be great if we had now half an hour to discuss, because there are so many interesting aspects. But I think the important thing is to reiterate that this is very much consistent with some data also from other teams, specifically the Cine Medical Center, where Rohan Dharmakumar and the team published papers on the ramifications of hemorrhage in a pig model, and that was partially involved in that. That's why I know these results were not only very consistent, but also very impressive in terms of the iron deposition that maybe stays there for long and makes the tissue actually electrically unstable, thereby possibly giving rise to sudden death, and also the inflammatory response triggered by the extravasation of erythrocytes, which is one of the strongest triggers we have for inflammation. So I think what you did here is great. You basically provided some really definitive data in a very well-controlled experimental model on this insult, and in fact, especially that you could show that the hemorrhage alone is already a problem. So that is difficult to not necessarily difficult, but it's important to incorporate it into the clinical thinking. If you have late reperfused MI, more than half of them have, as we know, have hemorrhage in there. So what does this mean? This is a severe side effect of the revascularization. So I think this paper could have very significant clinical implications, and I think we should promote that. So if you have urgent questions, just type them into the chat. But the question I have for you is, Nilesh, you said it's the follow-up paper of the first one. Is there be another one where you look at that in more clinical settings or in other settings, or modifiers or treatment or whatever? Any plans you can share with us? Yeah,
sure. I think the one which we actually I don't know if we talked about it, but there was so earlier this year we did publish in Basic Research in Cardiology, kind of follow up to all this is we did try to use an iron chelating agent in kind of a similar pig model, not with collagenase, but a typical IR sort of model, and there we actually did show that you can reverse some of these effects. Potentially, if you apply this iron chelating agent, you are able to clear these iron byproducts faster. You are able to have an impact on inflammation or edema by T2 at the 4-week time point. It also has an effect on adverse remodeling. So you actually have a beneficial remodeling process where your EFs are better. Your end-diastolic volume does not rise as fast as your placebo group. So that was very promising. Again, that was a pilot study, so it's not a very with few animals, but it was highly definitive in what we saw. So I think that's the direction to go ahead in trying to prove that, essentially.
Yeah. Okay, great. Thank you very much for sharing that. And again, congratulations to you. And I see that Graham is also on the call for your outstanding contributions to the field. That's really amazing. Before I hand over to Bettina, who will talk about the next one, just as an announcement, on Wednesday, December 9, so in a little bit more than a week, the JCMR Journal Club will be hosted by Scott Flam this time, and we'll discuss a paper called Accelerated High Resolution Free Breathing 3D Whole Heart T2 Prepared Black Blood and Bright Blood CMR. So what that means, that's work from Teresa Correa and Claudia Prieto, is basically new sequences to basically do everything in one big 3D data set. So that will be also very interesting. And now I hand over to Bettina, who will announce the next journal club for January. Bettina.
Yeah, thank you, Matthias. So the next journal club will take place on January 20th. So we postponed it a bit due to the holiday season, and it will focus on feature tracking again, with two very interesting studies. The first one from Alicia Maceira and colleagues from Spain on cocaine addicts. So very interesting topic. And the second one dealing with feature tracking for risk stratification in HFpEF patients. So also very interesting focused topic. And I'm looking really forward to the presentation of these two papers. And from my side, I wish you a very healthy holiday season and hope to see you in January. And with this, I hand over to Friedrich Matthias again. Thank you.
Thank you very much, Bettina. And from my point of view, also, thank you very much for joining. Mille grazie ancora una volta, Alessandra, and also to you, Nilesh. Thanks a lot again, and stay safe. Have a wonderful, peaceful, and healthy Christmas period, and see you next time. Bye-bye.
Bye.
Bye.